Professionals. I am Dr. Nadia Zainab, Technical Lead and Center Coordinator at Physiotattva Jayanagar, and it is my privilege to be hosting you tonight. It is our honor to warmly welcome you to our inaugural continuing medical education program, Current Trends on Neuro-Rehabilitation, organized by Physiotattva in collaboration with BTL India. Today marks a significant milestone in our commitment to advancing medical excellence and promoting continuous learning. We are thrilled to bring together renowned experts and thought leaders to share their insights and expertise. Our mission is to provide a platform for physical therapists and healthcare professionals to enhance their knowledge skills and professional development. This CME program aims to address the current trends in neurorehabilitation, fostering improved patient outcomes and advancing the field. We request the presence of our honored guests on the stage. I would like to call Dr. Murali Krishna P., Dr. Yolana Horasi, Dr. Shreyas Kadabim, and Dr. Anup Brahmabhat. I also request Mr. Vikas Sharma, Mr. Puneet Trivedi, and Mr. Sandesh Kadabam to join us for the lamp lightening. Respected guests, please remove your shoes and graciously participate in the sacred inaugural ritual. Console team, kindly cue the invocation song. I now request Dr. Murali Krishna, Dr. Yolana, and Dr. Shreyas Kadabam to please take their seats on the stage. Now, I would like to invite Mr. Vikas Sharma, Director of BTL India. Mr. Sharma is a pioneer in healthcare innovation, transforming lives globally through cutting-edge medical technology. Under his visionary leadership, BTL India has emerged as a global leader. We deeply appreciate Mr. Sharma's passion for excellence and his presence here today.
Dear esteemed guests and distinguished doctors and colleagues, I Vikas Sharma, Director of BTL India Private Limited. Welcome you all. Today, we gather to share knowledge, expertise, and best practices in the field of rehabilitation and physiocare. This platform offers a unique opportunity for meaningful interaction, insightful discussion, and professional growth. We are honored to host this collaborative event with the team Physiotattva for bringing together medical expertise, thought leaders. Thank you everyone for attending this event. Thank you.
Thank you so much, Vikas sir. Now I invite Mr. Sandesh Kadabam, co-founder of Physiotattva and managing director of Kadabam's Group. His unique vision to empower individuals with expert care for effective recovery and to enhance their quality of life has led to the emergence of premium healthcare services accessible to everyone through Physiotattva. Sir, I request you to come to the dais for the welcome speech.
Thank you, Nadia. I think you can have a side career in emceeing for sure. You're more than a physiotherapist now. Ladies and gentlemen, good evening. We're indeed honored to have each one of you all here. We do believe it's a privilege and an opportunity to host each one of you all. We've done CMEs, we've hosted, we've been part of multiple CMEs, but the first is always very exciting. And this one is the first for our community in physiotherapy. And each and every physiotherapist, physical health rehabilitation specialist, we value every single work that you do. My first welcome note and acknowledgement is for each one of you all in the audience. Thank you very much for being there. With due regard to the dignitaries on the dais, I do have an opportunity to have known each one of you all very personally. Of course, Dr. Murali Krishna, as an acquaintance that I've heard from various common colleagues and professionals. Jolana, it's been fantastic to have had you with us. It's indeed a privilege to have hosted you and have had those conversations. It's great to see the BTL commitment in coming forward in training, not just in the space of development, but taking that step forward in making it accessible and usable to this community. Thank you very much, and we welcome you to the gathering. Thank you. May I request my colleagues to felicitate Jolana, please? May I request my colleagues to felicitate Jolana? This is our traditional honor of felicitation, so we would request my colleagues to felicitate you. Thank you. Nia and Daritri, if you could join, please. Please join us. Thank you.
We would now like to felicitate Dr. Murali Krishna, Senior Consultant. Jolana? All right. We would now like to felicitate Dr. Yolana Horasi, Physical Therapist in British Columbia, Masters in Healthcare Management, Clinic and Product Specialist, BTL. Dr. Yolana, she's a physiotherapist and personal trainer and combines sports training expertise with hospital, clinic, and rehabilitation experience. Holding degrees in physiotherapy and healthcare economics, she advocates for integrating strength training and rehabilitation.
Thank you.
We would now like to felicitate Dr. Murali Krishna, Senior Consultant Neurosurgeon at Fortis Hospital. For this, I request Dr. Anup Brahmbhatt, co-founder and managing director of Physiotattva, to lead the felicitation. Dr. Murali Krishna, a renowned spine surgeon, shines with expertise and compassion. Trained at Osmania, he excels in minimal access surgery, correcting deformities and complexities. Affiliated with Neurological Society and Spine Surgeons of India, a life member of IMA, Dr. Krishna pioneers minimal invasive techniques.
So, ladies and gentlemen, this felicitation is our honor in welcoming our guest traditionally. I would like to welcome professionals from various walks of life. But before I move away from the dignitaries, two other special guests, or I would say my partners in life who are part of the stage today, is my co-founder Anup Brahmbhatt. Should I say welcome you? And my brother Dr. Shreyas Kadabam, a radiologist with MSK specialization, has done fantastic work and leads Kadabam's diagnostics. So it'd be lovely to hear him as well. I'll spend a couple of minutes while I could set the context, set various. I'll spend a minute or two to let you all know the work that we do as Kadabam's group, as Physiotattva, why this event, and what we are here to achieve. We have always believed in creating a very safe space for recovery. As Kadabams, being in the space of mental health and behavioral health for 32 years, it was but obvious that we had to do something in the physical health space. Physical health is not as a space that we've done in mental health. It had a lot of evidence-based interventions and recovery. Having known Anup for over a decade now, with personal journey and all the work that he has done, we did find it a collaborative opportunity, and that's where stemmed out Physiotattva. Physiotattva in the last 3 years has been growing aggressively in various frontiers. We have services in Bangalore, we have services in Hyderabad, and now due to launch our Neuro-Rehab. One area that we have particularly focused on is collaborative and cooperation. The collaboration in the space of healthcare services is where our future lies, and that's a space that needs to create a conducive environment. We stay invested in research, we stay invested in exploring spaces that is to be done in physiotherapy. You would have seen that commitment with the AI and the augmented reality that augmented reality that we have set out, and you have seen. You will see our AI chatbot. But moreover, it's these inquisitiveness that we have even tied up with Esvyasa University to have launched various courses in physiotherapy and onwards. Ladies and gentlemen, with adieu, I've moved from a welcome note to a quick background of why CME, but I will leave it for these distinguished dignitaries to take over the conversation. It's our first time for the physiotherapist community, so we're always open for feedback, and we would love to know what we could do better as we go on, but we certainly intend to make it a series. One final note, this couldn't have been possible without the dynamic leadership of Mr. Puneet from BTL, and certainly everybody from BTL India. We value, I go a step forward and say we value our partnership in everything that we have done from the first center to now and maybe the 100th center. Thank you very much.
Thank you so much, sir. Your speech was definitely inspiring. I now request our dignitaries to take their position in the audience. Without further ado, let us commence our CME. Calling on stage our first speaker, I am pleased to ask Dr. Murali Krishna to deliver about current trends and future perspectives of stroke management. Dr. Krishna began his medical education at SV Medical College in Tirupati. Earning his MBBS in April 2002, he continued his specialization on the same institution, completing an MS in general surgery in January 2007. Pursuing advanced training in neurosurgery, he received his MCH from Osmania Medical College, Hyderabad in August 2010. His career in neurosurgery began at BGS Global Hospitals, Bangalore, where he worked as a junior consultant from August 2010 to January 2011. He then transitioned into academia as an assistant professor in Department of Neurosurgery at Rangaraya Medical College, Kakinada, from February 2011 to August 2012. He later held a similar position at SV Medical College and SVRRGG hospitals in Tirupati from August 2012 to February 2014. From February 2014 to June 2023, he served as a consultant neurosurgeon at Fortis Hospital, Bannerghatta Road, Bangalore, before assuming his current role as senior consultant.
Good evening, everyone. I thank each and everyone for giving me this opportunity to talk on current trends and future perspectives of stroke management. Though it's a rehab CME, so I'll be mainly concentrating on the medical current trends of stroke treatment. So brain is a very delicate organ. So it doesn't have any regeneration capacity. So we have to preserve the brain. What is a stroke? According to World Health Organization definition is rapidly developed clinical signs of focal or global cerebral dysfunction, which is lasting for more than 24 hours or leading to death, mainly of a vascular origin. So the burden of stroke in India is increasing. It's a fourth leading cause of death in India and it's fifth leading cause of disability. The incidence of stroke in India is almost 100 to 150 cases per 1 lakh population per annum. What is the pathophysiology of the stroke? So the vascular lesions can be classified into either ischemia, which is 87% of it, and intracerebral hemorrhage, which is about 10%, and subarachnoid hemorrhage, which is due to rupture of some aneurysms. So what is ischemic stroke? 87% of the strokes are because of ischemia. Ischemia is nothing but a blood clot which is formed within the vessel and stopping the blood supply to the brain. So here you can see the blood supply going into each and every artery, but here it is blocked. So that part of the brain which has to receive the blood supply will not be receiving any more blood supply. So how will you treat the stroke? Either you have to remove the clot by medical injections or by mechanical thrombectomy. So how fast we have to give the therapy? So to understand simply, so whenever a stroke patient is stroked out, usually central area of infarct, that is called the core, which is completely irreversibly damaged, which there are no medications to cure that disease. But we are mainly interested in the area surrounding the core known as the penumbra. Here the neurons are potentially salvageable. So these cells in the penumbra are structurally intact, but they are dysfunctional cells. So over time, with the lack of perfusion to the penumbra results in an enlargement of irreversibly damaged tissues. You can see that in hours duration, the core is completely increasing. Over the days, the entire penumbra is filled with the irreversibly damaged tissue. So how will you recognize the stroke? So first thing is clinical diagnosis. Check for facial asymmetry and check for any weakness in the limbs and see how the speech is. If you are suspicious of stroke, then immediately shift the patient to the nearby hospital. So by the latest and advanced treatment for stroke, the paralysis attack, that is a weakness caused by the stroke, is reversible. At least we can reduce the severity of paralysis. How is it? So first thing, when the patient arrives at the hospital, we have to diagnose whether patient is having stroke or patient is having any meningitis or something else. So first thing is CT scan brain or MRI brain. The advantage of CT scan brain is we can quickly do it within 5 to 10 minutes. But the disadvantage of CT brain is immediately when the patient comes to hospital immediately after stroke, within first 2 to 3 hours, CT scan looks normal. The only reason why you are doing CT scan is to rule out the hemorrhage. If there is no hemorrhage and the patient is having clinically stroke, then it's considered to be an ischemic stroke. But the most sensitive imaging is MRI with the diffusion weighted images. So this is the CT scan. This is the early CT scan where you cannot differentiate whether it is stroked out brain or normal brain. But over the time passes on, you can clear cut. You can see this part of the area which is completely stroked out. This is the MRI patient, which I am telling you, this is the diffusion weighted images. This is the brain. Here you can hyperintense signal. This is called the diffusion restriction. So diffusion restriction in MRI brain is classically a sign of the stroked out brain. What are the other investigations which we have to do? One is the ECG and echo to see is there any clot formed in the heart and ascended up. Is that the reason for the stroke? Or doing a carotid ultrasound. So is there any block in the carotid arteries in the neck? Or next thing is MRI angiogram, CT angiogram to define the vessels inside the brain to see where exactly is the block. Is it the main vessel block or the capillary level block? So as you can initially within 10 minutes, the core area is very small, but as the time progresses, the core area will completely occupying the penumbra region. So why you have to reperfuse? Reperfusion means you have to re-establish the circulation in the brain. So if you reperfuse the brain, the core will be isolated. But if you don't reperfuse the brain, the entire penumbra will turn into irreversibly damaged core tissue. So what are the treatment options? If the patient reaches hospital within 3 to 6 hours and is established ischemic stroke, you can give a thrombolysis therapy. Or the patient comes after 6 to 8 hours, but before 24 hours, if there is a large vessel obstruction, not a minor vessel obstruction, you can go for a mechanical thrombectomy. So what is thrombolysis? Thrombus means blood clot. Lysis means dissolving the blood clot. So there are various medicines which you can dissolve the blood clot. These medications are called thrombolytic agents. So you can administer the thrombolytic agents through intravenous route, or if you are specifically more concentrated in dissolving the clot, you can put the catheter through the angiogram near the clot and give the thrombolytic agents. The current thrombolytic agents which we are giving are streptokinase, urokinase, and the latest ones are alteplase and tenecteplase. So though these medications we can give thrombolysis, they have some inherent complications. Like you want to dissolve the clot in the brain, there can be chances of spontaneous hemorrhage elsewhere in the body. And the patient has to come to hospital within 6 hours. So the patient comes to hospital after 6 hours. What is the treatment? Then though we give thrombolytic therapy, 80% of the patient with cerebral artery occlusion fail to show recanalization. So in those patients, we can opt for a mechanical thrombectomy. So these are the non-pharmacological medications. We are not giving any medication. These are purely endovascular therapy, where you can go and remove the clots. How we can remove the clots is through an angiogram here. You have to, through the groin, you have to put a sheath into the femoral artery. From there, you have to insert the guide wire and the catheter. Once you reach the clot, you can pull out the clot. So what are the ways of removing the clot? This can be either coil retriever or aspiration device or a stent retriever. Coil retriever is nothing but interventional radiologist deploys the loop of coil through the clot to engage the thrombus and then pull out the thrombus, like how you remove a cork from a wine bottle. So these are the various types of coils which are used to remove the clots from the blocked vessel. Or else you can put a catheter close to the clot and then you simply do the vacuum aspiration to remove the clot. Or the latest technology is stent retrievers. Initially, a stent is deployed into the thrombus, and then you have to deploy the stent. Once a stent is deployed, it will completely occlude the blood vessel, pull the thrombus into the stent. So both you can remove at a time. Can you play this video? It's called mechanical thrombectomy. You are not worried about the small vessel disease. In the small vessel disease, you are mainly give thrombotic therapy. You are mainly worried about the large vessel obstruction, where the blood clot is there and sitting and completely up. In this way, you can put a catheter through the femoral artery, sending up with the iliac artery, descending aorta, go across the common carotid artery, go to internal carotid artery, identify which vessel is blocked, put the catheter there, remove the catheter. Once you remove the catheter, stent, this is undeployed stent. Then after that, we have to deploy the stent so that you can remove the clot completely. This is the mechanical thrombectomy. So after clot removal, you have to shift the patient to ICU, put some arterial line, center line, and start the nasogastric feeds and put the Foley's catheter. And you should strictly control the blood pressure and sugars. And we should avoid the medical complications like aspiration pneumonia, deep venous thrombosis. General treatment is like giving aspirin and other antiplatelet medications. As soon as the ischemic stroke is diagnosed, we should give the platelets, antiplatelet medications like aspirin, clopidogrel. But if your patient is undergoing thrombolytic therapy, you are not supposed to give the antiplatelet medication till at least 24 hours after the therapy. What other treatment you can do for a stroke? Suppose the patient is stroked out. And if there is no proper reperfusion, you can see the entire part will become a core tissue. Once the core tissue means there is lack of blood supply. So once there is complete lack of blood supply, this triggers inflammation, which can causes the edema in the brain. So once there is edematous brain, it cannot expand out of the skull cavity. So what happens? There will be a lot of pressure accumulation. That is called raised intracranial pressure. So in such cases, patient will be worsening. They can become unconscious. They can go on ventilator. So in such case, what we have to do the decompressive hemicraniectomy. So decompressive hemicraniectomy means you have to remove a piece of bone. At least what we'll tell is to remove at least 13 centimeters diameter bone has to be removed, so that we have to allow the brain to expand. Once brain will get extra volume, the pressure inside the brain will come down. In that way, you can save the patient. So in spite of all these thrombolytic therapies and mechanical thrombectomy, still we have having certain challenges, like incompletely recanalized vessel due to intervention. So even though if you do recanalization, so there can be reperfusion injury. That means the ischemic brain, once it receives blood supply again, there will be a lot of inflammation happening in that brain, which can cause some kind of problems, what we call as hemorrhagic complications or edematous complications. So how to sort out this tech? This is the recent technology where it's called nanotechnology in the stroke. What is the nanoparticles or submicron size particles, typically in the size of 50 to 300 nanometers. So nanoparticles are formulated using different biomaterials like lipids, metals, polymers, which are synthetic or natural. We have to thrombolytic agents, we have to mix with these nanoparticles. This helps in penetrating the tissues more properly. So nanomaterials can be used for early stroke diagnosis, thrombolytic-based nanomedications, where the thrombolytic agent will go and specifically go and stick to that blood vessel, the blood clot, which helps in thrombolytic therapy. In the same way, neuroprotective agents, we can mix it with nanoparticles, allow them to into circulation. They can cross the blood-brain barrier and specifically go to that stroked-out brain. And there are certain medications to reduce the infection after the stroke also. So mainly, what are the advantages of these nanoparticles in the stroke therapy? These are called expanded treatment window. Suppose you want to give the thrombolytic agents, but the patient comes after 6 to 8 hours. In regular thrombolytic therapy, you cannot give it. But with nano-coated thrombolytic agents, you can give even after 6 to 8 hours also. It helps in prompt delivery of thrombolytic agent, protective agents, especially into the stroked-out brain. And it helps in complete recanalization. And also it can reduces the complications of IR injury, means reperfusion injury. They can prevent the hemorrhages, they can prevent the edema. So these are the advantages of nano medicine in stroke. Then what about hemorrhagic stroke? Hemorrhagic stroke, which leads to 13% of the stroke, these are caused by rupture of blood vessels inside the brain. So what is the treatment of it? Try to stop the bleeding and manage the intracranial pressure. So once there's a blood clot inside the brain, so the brain cannot expand. So there will be a lot of pressure building up inside the closed cavity, skull cavity. So ICH is a devastating form of stroke characterized by bleeding into the parenchyma. The mortality from ICH remains as long as 50% at the end of 1 month. So it's a very, when compared to ischemic stroke, hemorrhagic stroke is more dangerous. So how will you control this mechanism, this injury from the hemorrhage? So you should understand the pathophysiology of the injury. There is a primary injury. Primary injury is related to mass effect. So once the blood vessel ruptures, there will be accumulation of clot. So that causes pressure inside the brain. This is called the mass effect. So secondary injury, what happens to secondary injury when the blood vessel ruptures for the duration of weeks? There can be a lot of inflammation pathways going on inside the brain, and because of the blood products and iron-related products from the blood, they can cause direct toxicity to the brain, and there can be a lot of oxidative stress. The primary hemorrhage, the primary injury, it's unavoidable. Our area of interest is mainly to prevent the secondary injury. So this is the hematoma. Once the hematoma is formed, it can cause mass effect. So this is the primary injury. The secondary injury is because of blood-brain barrier breakdown causing edema. Again, they can trigger the inflammatory pathways. Their hemoglobin products and the iron products can be cytotoxic to the cells, and there will be oxidative stress. These are all the secondary injury. This primary injury, which we can't do anything. Our area of interest is to prevent this secondary injury. So what is the main the mainstay of initial treatment is medical management, admit him in ICU, aggressive control of blood pressure, because hypertensive bleed on BP on arrival to hospital will be or always more than 160, 180 like that. So you should strictly control the blood pressure. A lot of patients, like they'll be taking antiplatelets or anticoagulants. If the patient has taken antiplatelets and anticoagulants, you start concentrating on reversing those actions. And you have to prevent the secondary brain injury by preventing the seizures. You should reduce the ICP, you should control the blood sugars and fever, and strict BP management. How will you reduce the ICP? So you have to keep the head end elevation like 30 degrees so that their edema will come down inside the brain. That is the most common thing. And you should give some sedation to the patient so that the metabolic requirements of the brain cells will be less. In that way, the inflammation also will come down. You can ventilate the patient and hyperventilate so that you can reduce the ICP. You can use a hypertonic saline of mannitol. This helps in reducing the edema. Or in certain patients, what you can do, you can put a catheter inside the brain. You should continuously monitor the ICP. If you feel that ICP is going high, then again aggressively you would start giving mannitol or hypertonic saline. This is about the ICP management, non-invasive. How will you invasive therapy? Suppose IVH is nothing but, ICH is nothing but forming of hemorrhage inside the brain. Sometimes what happens, this hemorrhage is spills into ventricular system. You know the ventricles are the fluid-filled spaces within the brain. So sometimes there can be massive accumulation of blood into the ventricle. So in such case, what we have to do, we have to put a ventricular drain. What is a ventricular drain? We have to put a catheter into the ventricle and allow it the CSF to come out. In that way, you're removing some of the CSF from the brain. It can reduce the pressure, and you can monitor the ICP. And simultaneously, you can inject the thrombolytic agents. You can slowly inject into the catheter to dissolve the clot. So these are the ventricles. So normal fluid-filled spaces within the brain. So sometimes there can be hemorrhage mainly into the ventricles. So in that way, what we can do, you can put a catheter. It's called external ventricular drain. You can put a catheter. Once you put the catheter, slowly the fluid will come out from inside out. In that catheter, you can start injecting the thrombolytic agents. So it completely dissolves the clot. This may be after 1 month, you can see the brain like this. This is one of the mechanisms of surgical management of intraventricular hemorrhage. Suppose a big blood clot which is surfacing, then you can do a surgery, remove the clot, you can reduce the pressure inside the brain. There is one more, this is an invasive procedure. There is a minimally invasive procedure where the blood clot is there which is not accessible. You can put that catheter directly into the hematoma cavity and start injecting the thrombolytic agents. This will dissolve the clot. So slowly over duration of 2 to 3 weeks, the scan will be like this. Is there a nanotechnology for intracerebral hemorrhage? Yes. Apart from the medical and surgical management, this nanotechnology helps in preventing further bleeding inside the brain, and also it can prevent the secondary injury. So this is basically about management of hemorrhagic stroke and the ischemic stroke. Then coming to physical therapy. So rehabilitation is probably one of the most important phases of recovery for many stroke survivors. The main objectives of rehabilitation therapy are to enhance the patient's functional capabilities, foster the self-reliance, and enhance their overall quality of life. So physical therapy is one of the most prevalent types of rehabilitative treatment provided after stroke. Physical therapists work with stroke patients to improve their strength, coordination, and balance with the goal of helping them regain the ability to perform everyday activities such as walking, dressing, and bathing. So therapy may include exercises, stretching, and range of motion activities, as well as training on mobility aids such as walkers or canes. Occupational therapy is another important part of post-stroke rehabilitation, which helps them regain the ability to perform daily activities such as cooking, cleaning, and personal grooming. This involves patients such as installing grab bars in the bathroom or using adaptive equipment such as specialized utensils for eating. So apart from speech therapy, when the patient has stroke on the left side, the speech will be mainly affected. In such cases, speech therapy is commonly used to help the patients recover their ability to communicate effectively. So speech therapists mainly work on patients to improve their speech, their language skills, their communication skills, as well as they will address the swallowing difficulties also. Other rehabilitative treatments are music therapy, recreation therapy with cognitive therapy, which they are going to explain. So it's basically a comprehensive approach. It helps in regaining the patient's strength, coordination, and improve the mobility skills, improve the communication skills, improve the cognitive skills and the social skills. So what is the next, the latest thing is, what is stem cell transplantation? Because I told the brain is very sensitive organ. It doesn't have any regeneration capacity. Once the cells are dead, the cells are dead. We cannot get new brain cells in place of the dead cells. So the latest technology is the transplantation of stem cells. What are stem cells? Stem cells are special human cells that are able to develop into many different types of cells. So the stem cells are placed in the brain, they develop into brain cells. The cells are placed in the muscles, they develop into muscular cells. So they can also help in reducing the inflammation caused by the stroke. So what are the sources for this stem cell? These are mainly obtained from umbilical cord of the fetus, fetal brain, and also from bone marrow. When these stem cells are injected into the ischemic area, then they can have neurogenesis, means regeneration of a new brain cells, and it activates the endothelial cells. It helps in formation of new blood vessels. Simultaneously, it can reduce the inflammation. Astrocytosis is nothing kind of reactive inflammation. So these stem cells are proven to reduce the inflammation and astrocytosis. So what are the proposed usefulness of the stem cells is improved physical coordination and posture, improved speech, increase in overall muscle strength, and improved sensations all over the body. This is about the stem cells in briefly. So to conclude, the onset of stroke is very dramatic and discouraging event both for the patient and to the family. The person who is completely independent will become dependent in a matter of minutes. The advances in acute treatment are saving the lives of the people who would not have survived in the past. So mainly the nursing and rehabilitation professionals play a critical role in the care of the person with a stroke. So we all play a role in improving the outcomes through education, training, and knowledge about the physical and psychological effects of a stroke. It is our responsibility to become familiar with the roles and responsibilities of each profession involved with the post-stroke care, as well as we should keep updated with the latest advances in treating the stroke. Thank you.
Thank you, sir. I will now invite Dr. Dharitri Brahmabhat, Clinical Director and Corporate Wellness Head at Physiotattva, to present a vote of thanks for sir's insightful presentation. A round of applause, ladies and gentlemen. Now, may I invite our second speaker, Dr. Yolana Horesi, to speak on brain plasticity and motor recovery with robotics. Ma'am. Dr. Yolana is a physiotherapist and personal trainer with a background from sports training. After completing university studies in physiotherapy, she gained experience in hospitals, private clinics, and rehabilitation centers as physiotherapist. She also finished a degree in economics and management in healthcare. As a physiotherapist and personal trainer, Dr. Yolana believes in the integration of strength and conditioning training with rehabilitation, recognizing the immense benefit it offers both patients and practitioners.
Good evening to everyone. Thanks for a very nice introduction to all of you and also for welcoming me so well in India. My name is Elena Hříší. I'm a clinical specialist and physiotherapist, but my main activity now is to train doctors, physiotherapists, and around the world in high-end technologies, including robotics as well. My today's topic is brain plasticity and motor recovery with robotics. So my main goal is to give you information and knowledge how you can improve your therapy outcomes with especially neurodegenerative diagnosis and neuro patients, but as well with other group of patients, orthopedic and potentially sports medicine and athletes. I will start with describing what robotic is, although I'm perfectly sure that everybody knows devices, knows robotics, and all of you probably have already some experiences with robotics in general. And explain why do I think that it's so beneficial to use these type of devices in rehabilitation. So use of robotics definitely helps us to reduce, to improve patient's outcome during the therapy. And it's generally working autonomously with the patient or with some small intervention from side of the therapist. Rehabilitation with using robotic devices serves for the therapy itself, but as you will see during the following part of the presentation, it's also a great therapeutic and assessment tool. There are, let's say, three main goals of using robotic rehabilitation or robotic devices in rehabilitation processes, when the first one is definitely to support movement of patients. The second main goal is to facilitate exercises of upper limbs, lower limbs of whole body, which is in most cases essential so as to perform proper treatment for each patient. And lastly, and what I will focus on during today's presentation the most, is to retrain motor skills. I'm sure that all of you work with motor learning and with neuroplasticity in your practices. And as you probably all know, the neuroplasticity is the process that is crucial for any patient suffering for some neurodegenerative disease. Might be stroke, Parkinson's disease, cerebral palsy, multiple sclerosis, or even spinal cord injuries patient. In these cases, our main goal is to do proper motor learning and as well to support the neuroplasticity process. But there are also other group of patients that appreciate and that really benefit from using robotic devices, such as orthopedic patients and such as athletes, sport clubs, and people with the need for performing big physical effort to their sports activities. Neuroplasticity is generally the process when the neurons are reorganized and where the process of formation of new neural connection, which is then fundamental for learning motor skills, for re-education of gait or any movement stereotypes. And this is what we need to gain in most of these neurological patients. Motor learning itself is the process of implementing the neuroplasticity to the treatment, and the goal of it is to restore functions of the patient, to support him in movements, whether he is not able to walk, to run if athletes, whether he is not to do activities of daily living in general that are necessary for daily life activities. And generally, all of this is then used in rehabilitation and sports training. Regarding neuroplasticity and motor learning, there are few main aspects that are necessary so as to support neuroplasticity processes and so as to support motor learning. I highlighted 5 of them, although there is a wider number of all of these activities or aspects. When the first one is task-specific training to do specific activities such as walking or trying to eat or doing any kind of activities of daily living. Other essential part of regaining walking, or not only walking, but any movements, is definitely real-time therapy feedback or biofeedback in general. Then motivation and encouragement is essential part of whole rehabilitation process, loading and tracking the process, and lastly, high repetition and consistency. Now, I will look at all of these aspects in more detail, and it will explain why is that clinically important and how do we reach all of these aspects with using robotic devices. So speaking about performing high repetition and consistency, then definitely, then more the movements, the particular movements we do in a time, the more we strengthen the cells inside the neural pathways with these repetitions. So this is basically the reason why to do so many repetitions in the therapy. The second aspect that I mentioned are task-specific activities, which means doing exact activities again on a daily basis or as regular as possible, which then helps the brain to relearn these specific movements. Again, it might be connected to hygiene, to walking, to any sports, but doing this activity as often as possible is generally what retrains us and help us to improve the therapeutic outcome. Then there is aspect of real-time or immediate therapy feedback, which might be provided in many different ways. I'm almost sure that some of you maybe use mirror therapy for having immediate feedback during the therapy in hemiplegic patients or in stroke patients, for example. And as well in robotic rehabilitation, we do have tools that provide you with immediate therapeutic feedback, which also offers motivational aspects. That is other part other aspect of motor learning. Because if we motivate the patient enough with using some games, with our words, of course, then the focus on neuroplasticity is again much higher. So just to summarize it, real-time therapy feedback and motivation is another aspect that is essential for supporting the neuroplasticity processes. And lastly, there has to be some loading of the progress. It doesn't really matter whether it will be connected to speed that we will use during the therapy or whether we will progress the patient in games, especially speaking about children's, or whether we just prolong the time of the therapy itself. But still, some type of progress has to be there. I, just for an example, showed you reports from our devices, and effector devices are gated, so you can see here in the banner, where we can provide with parameters connected to time, speed, a number of steps done during the therapy that are a great tool for the patient so as to know what shape he or in which condition he is currently, and as well for the therapist so as to know how to load the progress for the future. Regarding BTL devices and regarding product itself, I would like to say that we can offer, or that we offer actually, treatment for upper and lower limbs, which means that we can cover wide range of indications and wide range of patients, such as stroke patients, Parkinsonian patients, spinal cord injury as well. These devices are developed the way that they can be used in acute stages, intermediate, and as well in chronic stages of all of these conditions. So all of them are also covered. Thanks. And I'm going to start with treatment of lower limb now. There are two devices that represent robotics, speaking about treatment of lower limbs in BTL. The first one is end effector device, and the second is anti-gravity treadmill that allows a patient to be unweighted till 100% of their body weight, which means that, if I make it like really simple, they are like walking on the moon during the therapy which allows even patients who cannot bear the weight of over both legs to train, to verticalize, to restore mobility, and let's say in some like gentle way strengthen muscles if they are really weakened. I'm going to start with the end effector device. End effector means that the forces that are delivered from the device to the tissues or to the body are delivered through distal part of the body, which means that if I speak about lower limbs, the forces start in an ankle. If I speak about hands, then it means that the wrist and the palmar part of the hand is attached to the therapy. The signature of end effectors is also the fact that these distal parts of the body are attached through a single body segment, which means that the patient is not somehow like intensively supported and really stiff braces or some stiff level of support, which is one of the main factors that supports the natural walking pattern. End effectors, in our case, end effector R-gait, was originally developed for stroke patients because they have the highest potential of re-educate, especially in acute stages, of re-educating the walking or gait patterns, but as well it might be used in other neurological conditions, such as cerebral palsy, typically, or multiple sclerosis. I also treated somebody with ALS, like amyotrophic lateral sclerosis. Of course, in this case, unfortunately, we are not able to treat the cause of the problems, but at least, again, to verticalize the patient and to support him in walking, which at least is good for physical and as well mental health at the moment. End effectors, as you will see in the video in a while, are based on active motion from the foot that is done like through flexible foot plates, which allows you to do great plantar flexion and dorsiflexion during walking. It also allows movement in all three planes, so the patient is able to do flexion, extension, rotation of pelvis during the treatment, and as well abduction, abduction if necessary. During the therapy, there are two phases that have to switch so as to support the natural walking pattern, the standing phase and the swing phase. I will just turn on the video. Yeah, it fell to me.
Would you want us to play this or video or something?
Yes, I need to play this video. Doesn't work now. Thanks, Marvin. Like before it worked, but. Okay. So I will continue then. Thank you. So sorry, so I will not show that properly, but maybe I will try to somehow fix it during the presentation. But so as you to imagine how R-gait looks like, so it's the device that includes the flexible foot plates, including pressure sensors, so as to detect the movement during the therapy and so as to provide the patient with the feedback immediately. Here you can see the pelvic part that is also moving during the treatment so as to support all movements in the pelvis, which is also fundamental for supporting natural gait pattern. And this is the dynamic body weight support. That's the system that moves up and down And if you connect all of these aspects, like flexible foot plates, enough of plantar flexion, movement in a plane, and dynamic body weight support that supports to you to do the swinging and standing phase while walking, and then biofeedback that is provided through approximately 10 games that are included in our gate, then we are doing, I would say, maximum for motor learning and for regaining neuroplasticity processes. Our gate is used in children and as well in adult patients. So again, we cover quite a large group of patients and large group of indications. And what I would also like to highlight here is that easily operated just through wireless tablet, so even the manual labor of the therapist is not anyhow demanding. But there are also some devices that are dedicated or intended especially for people or patients who are more advanced. One of these devices is anti-gravity treadmill called R-Force. R-Force is a device that enables patients to be unweighted till 100% of their body weight. It's thanks to the fact that the patient is standing on the treadmill. Over the patient there is the chamber, this bag, and the treadmill measures the patient weight. And based on this, it generates the necessary amount of pressure that will unweight the patient to this 100% of his body weight, or to even like lower intensities if necessary, or lower unweightings if necessary. So as you can imagine, and as I also mentioned, this level of unweighting is extremely useful in orthopedic patients right after the surgery, if you want to train with them immediately. But if there's some limit that do not allow them to walk properly, like surgery of hips, for example, or even knees and ankles. So you can train even in these acute stages of the surgery, and still, even though the patient is not allowed from the doctor or from the character of the diagnose to bear the weight to 100% of the body weight. So orthopedic patients are definitely one of the groups that appreciate using R-Force. Then another big group that uses this anti-gravity treadmill are athletes and sport clubs in general. They use our gait not only for the treatment, but as well for diagnostics and for motivation and for gaming. Because you can see that the bag is like invisible and you can see through that. So right during the therapy, the therapist can observe what's happening inside the bag, can react on it, and can interact with the patient and improve their gait stereotypes immediately. As well, they are used in post-surgical and post-injury stages, and one of the other big group are neurodegenerative diseases. Here I just have to distinguish between R-gait and R-Force, because R-gait is from its character more for severe patients, while training on R-Force is for those who at least have some level of stability and can attend the device, but otherwise they can train in there. I would also like to share with you two clinical cases regarding using anti-gravity treadmill. When the first one is with a 62 years old patient from France suffering from Guillain-Barré syndrome. This patient had a treatment conducted from R-Force, and if it works, I will show you how the therapy went. Mm. Or, I'm sorry, isn't it a possibility? Yeah. Great, thank you. So in the first video, you can see that the patient, he has some really limited level of stability, and requires a big support from the side of therapist. But also, his stability skills are on a low level. Still, thanks to using the treadmill, he was somehow able to stand and then a little walk. So they firstly started just to verticalize, and after that, they tried small movements. Can I ask to play the second video? This video is the third session after 3 other days, where we can see the big difference compared to first session. So, of course, there are still some limits, but the patient has some level of stability. He's able to stand by himself. He's just supported by the handrails here, but there is no need to be supported from the side of the therapist. So we can say that it's quite a big success, because if you compare these 2 videos and imagine that they are only 3 days between them, so the difference is really huge. I'm sorry, there should be one more slide before. Yeah, this one, thanks. And this is the second clinical case that I would like to briefly share with you. This is about 30 years old football player after ACL reconstruction. He also had some complication with his knee joint in the past, but the main problem was the ACL reconstruction. So the patient came for the therapy with the support of braces, and the goal and the initial stages was to walk with him and train walking stereotype. And also, of course, activate muscle and keep some mobility in the knee joint mostly. So can I ask for playing the video? This one. So they started training walking with really small speed, and you can see that there is a small amount of unweighting. And as the patient was not really able to walk properly without any unweighting, still this was quite a big progress for him. Can I ask for the second? This is from the frontal perspective. Here you can better see the level of unweighting and the way how the patient behaves and how he walks during the therapy. And I ask for last 2, please. This is at the side perspective. And lastly, what I did not mention yet is that you can train straight walking in R-force, then reverse, and as well side walking, so as to cover the biggest possible groups of patients during the treatment. And this is also something that is used on really regular basis. There are also possibilities of doing uphill walking and changing the speed, of course, so as to make progress. I also want to share some successful stories of using R-Gait, because there are few athletes in the world that had a great results with using it. The first one is Johannes Frey, the Olympic medalist from Germany, who is really very good in judo. And as visible in the picture, he's the one who uses R-Force. Then there is a second, Julimar Rojas Rodriguez, multiple Olympic medalist from Latin America, who also uses R-Force for training and for prevention of possible injury. And the last one, I will not speak only about famous athletes, but as well about famous physiotherapists. So this is the physiotherapist who took care of David Beckham in the past, and he also started using R-Force for for his patients. Even in R-Force, there are some motivational aspects. One of them are definitely games. There are 7 different protocols dedicated to gaming in the anti-gravity treadmill that targets to different skills connected to walking. The most common one are observing the symmetry of patient gait pattern. Then games dedicated to observing reaction time and reaction itself during the therapy. And lastly, some games, their goal is to see what is the step length, step height, whether is it all the same during the therapy. And these are the perfect therapeutic tools, diagnostic tools at the same time. They also provide real-time therapy feedback, so we can see that is the other aspect that supports the neuroplasticity and motor learning processes. And it also motivates the patient. So as well, this is other aspect of supporting the neuroplasticity. Last thing about R4s is that even there we can do exportable reports that show us the progress of the patient, and that they are like good therapeutic tools to somehow load the progress. I just put like these butterfly diagrams here. That should be look like the butterfly and be more or less symmetrical in both sides. As you can see in all of these pictures, it's definitely not symmetrical. So this is the butterfly diagram of Parkinsonic patient who does really short steps. This is of the patient who is limping to the right leg. This is for cerebral impairments, the problem with coordination, and the last one is just antalgic walk. So even from these small diagnostic tools, you can recognize some really interesting parameters about walking. And then there are tools serving for upper limb treatments. I will again start with those who are for acute and, let's say, less advanced patients. We again provide two different technologies, R-Touch and R-Lead. While R-Touch is, as I said, for more acute patients who cannot move with their hands properly, it's very good for neurological patients, again, for all of these groups that I described before, such as stroke, spinal cord injury, Parkinsonics, and so on. While R-Lead is a sensor-based technology, more designed for advanced one. I would also like to say that one of the aspects of using R-Touch technologies is based on mirror neurons and is based on mirror therapy, although in more advanced way. So as to regain motor control and to reduce pain, we again use some tools from mirror therapy to activate the mirror cells, the mirror neurons, to reorganize and create new neural pathways. This is the R-Touch product. This is based on the robotic glove that generates flexion and extension of the fingers, passively mostly. And during the treatment, the patient has, again, immediate feedback of his movement, whether he does it correctly or not, and he can also interact with his healthy hand, whether one is healthy. Again, as you can imagine, it proves and supports all of these aspects of neuroplasticity. So you can see that the patient does many repetitions during one treatment. He's got immediate feedback. He is motivated through different games that are also designed in the software, and he's doing task-specific activities. These are the group of patients typical for using R-Touch product. Practically and clinically, the goal of the patient is here to restore mobility and to be able to move again. So during the training, it's typical to provide and train activities of daily living, such as grasping subjects, such as shaking hands, such as eating, doing hygiene, or something like that. And this is something what we can definitely train while using R-Touch. It's also the technology that is used in children as well in adults. And besides being used for ADL activities, it's also used for action observation therapy. So to summarize this technology, Then R-Touch serves for hand mobilization, passive hand mobilization, whether the patient is not able to move with his hands alone. It also works with aspect of mirror therapy that, as we mentioned many times, serves for training neuroplasticity processes and neuroplasticity process. But it can be also done like active patient-directed upper limb training, which means that patient shows with a healthy hand what the ill one should do. So again, this is based on like mirror therapy and on a motivation as well. And there is also a way of providing active assisted training, which means that the therapist does the therapy with the patient together and motivates him and leads him which movement should be done. And the last product and thanks. The last part that I'm going to describe is a product designed for upper limbs treatment, again for more advanced patients. The product is called R-Lead and is based on a sensor-based technology for upper limb, where like the aim of the therapy is to move with the upper limb, with whole the limb, and through, again, motivational games, motivational software and designed aspects, provide designed movements. This is again used in neurological patients, musculoskeletal disorders, but as well for cognitive recovery, if we need somehow to train also the mental health and cognitive part. R-Lead is based on the fact that there is an optical sensor that reacts on the movement of the arm. The patient's arm is fixed in a specific arm that allows the patient to do all movements of the wrist, such as plantar dorsal flexion, pronation, supination, flexion and flexion extension, and ulnar radial ductions. And all of these movements are detected during the treatment, and the patient is pushed to, for example, grasp some things, or to collect mushrooms, or to go shopping, which again is something that children and adults are very interested in usually. In here, we showed how you can play, or how the therapy looks like. So the patient arm is inside the arm, and he's playing one of many games that are installed in the software. And the goal is to move with the impaired arm to get the biggest possible score and to be better next time. So, to summarize, I would like to highlight that robotic rehabilitation plays a fundamental role in neurorehabilitation, but as well in treatment for orthopedic patient and sports patients. There are few main aspects that lead to effectiveness of its treatment. Definitely it's precision and consistency that supports like being able to do such activities regularly. It's high repetition, definitely the wave of applications that serves for effective neurorehabilitation and sports medicine in general. But definitely, a big aspect of robotic rehabilitation is the fact that it saves therapist's hand as well, because the therapists do not have to do all the work manually, which from my experience sometimes is really demanding to put so much physical effort to like movement with some type of patients. And as well, it usually seems to be very interesting for patients as well, speaking about the game, speaking about pushing the performance to better level. And the real-time therapy feedback and motivation is something that is really well done in robotic devices in general. Through robotic, we can treat all the body, upper, lower limb as well, depending on the impairment, and as well wide range of indications, which mean wide range of patients that we meet during our practices. That was all from my side. Thank you very much for attention.
Thank you
and
so
wish
much,
you-
Dr. Jolana. I would now call upon Dr. Manjari Thakur, Vertical Head, Product and Strategy at Physiotattva, to present a token of appreciation for Dr. Jolana.
Oh, yeah, sorry. Thank you very much. Thank you very much.
Improvements, we've seen an end effector with one trajectory on the part, coming up with better quality in the part of chronic stroke care, whereas in the part of exoskeleton, it works with higher intensities and it works with better in the locomotor, the gait training part of it. When we say aquatic therapy, again, this is the heart of our physiotattva. Any person who have questions on the part of aquatic therapy, I must say you can have a talk with Dr. Suresh. He's the one leading in the part of physiotattva with the aquatic therapy. We have recently identified that the limitations, I'll directly come to this limitation, the accessibility, the poor awareness, and limited understanding on the part of aquatic therapy by a neurophysiotherapist. So what we saw on the part that the buoyancy rule, the water depth rule always creates on the part of proprioceptive floating. Not only it increases the sensory part of it, it increases the sensory motor, thus with the cardiovascular as well. So the combination, the holistic approach that we have already been registered, we are delivering to the best, to the point that this comes into the practice. These two pictures are one picture is from our the current going patients, and this is something that we are coming up with recent launch. Body weight supported treadmill training. This is one thing, again, it's been there since long, but then we see the current trends in the part of dose reported. So the dosage in the previous research articles was varied. There was no level A evidence on the part of dosage, but recently we saw that 4 to 8 weeks, 5 times per week has been reported a better recovery into that particular robotic body weight supported training. We have seen the improvement in Berg balance scores as well and gait speed. Improvements in swing and stance phase is something that we will see with the part of body weight supported training. One thing that came very recently is the part of these body weight supported training works much better in the proximal muscles rather than the distal muscles. So where we have seen it goes with the multifunctional, multidirectional enhancement after the body weight supported treadmill training. And we have different stripes of it. It could be used on the treadmill part, it could be on the part of locomotor, it could be just a suspension unit and we can walk around to the parts of rounds. It can work in all the way, okay? Make it more efficient, make it more used to in the part of clinics, it's always there. When we say constraint induced movement therapy, again, CIMT has been always, again, one of the very recent advances, which we have started with the part of stroke. Few of the implications that I wanted to bring with the part of CIMT is the very, very recent advances has made that the effects in there is retained for a very longer period of time. So if you do CIMT, it comes into the part of not achieving the goals, not having a neural plasticity around, but it is also evoking onto the part of retainment compared to the other conventional or other therapies. Mental imagery, I am a high practitioner of mental imagery. I use on the repetitive task, I be very specific. It could be a kinesthetic, it could be a sensory, it could be a motor, anything on that particular need is required. What we saw in the part with mental imagery, not big gross movements can be affected, but the time, the acceleration time can be increased, and the duration can be decreased for that particular movement. So these implications has to be found really on the part of spasticity to initiate the movement to a person who falls into a severe category. We have started this mental imagery with EEG services, with EEG combination in order to see the kind of fluctuation we have. We can see from the flexor carpi radialis and extensor carpi radialis, before rest there was this kind of fluctuation, and with mental imagery these kind of fluctuations has brought up. Mirror therapy not only works with the cognitive part, it works with the unilateral neglect, it works with the motor part, it works with the sensory part as well. So mirror therapy, you can use a box, we can use big frames in order to produce the mirror neurons excitation. This works on the part of interhemispheric excitation. Eccentric controls, these are eccentric controls have recently been known to decrease the spasticity and also increase the endurance for a person who is suffering from the stroke. So in case if you wanted to have a chit chat on the part of eccentric control, we can always have Dr. Sumit around in order to have that discussion. The next two slides are on the transcranial magnetic simulations, and this slide is on TMS, transcranial magnetic stimulations. Unfortunately, I have only learned about it, I have not practiced about it, but soonest we can expect to have a good practices of TMS. Again, it's very easier. The ipsilateral, the same side of hemisphere has to evoke and the contralateral hemisphere has to inhibit. So the currents are passed into the such way that these comes into the part of a proper reciprocal inhibition. So what we have seen in the high frequency, there are two types, low frequency and higher frequency. Lower frequency have more effect on the upper limb functions, whereas high frequencies are on the part of motor control, motor trunk, and gait parameters. Transcranial direct brain stimulation, again on the part of anode and cathode, which depolarize. It evokes cortical excitation in affected hemisphere and inhibits into the unaffected hemisphere. So these are the things now I wanted to bring that has a huge impact on the part of stroke rehabilitation. This comes when I was in the part of a team where we have to see the extensive stroke rehabilitation patient, the family education program. The family education program, be it the counseling of the family members or the awareness of the disease or the impact on the quality of life that one has to attain, the proper answer of that, the proper cross counseling of that is very needed. So what we have seen in recent time, that it should be a customized, it should be interactive, it should be a computer based, and it should be in a regular sessions. It should not be only that one time the education has to be delivered and we can take it off. And this has been taken very seriously in the part of my organization, where we deliver the part of cross consultations and consultations, reconsultations to our family members in order to make that huge impact on the part of understanding. When we say the family-based programs, we saw that not only it reduces the burden, but also it helps in not to induce more of the depression in the society and make it very clear with the family members. Home-based physiotherapy. Home-based physiotherapies are core of the physiotherapy in Physiotattva. We are currently seeing n number of cases in the part of stroke rehab, where we feel the efficiency of the care we give, the therapy we give is as efficient as we give in the part of clinical setups. And this has already been proven by one of the articles which is addressed in 2022. In case if you wanted to have a chit chat on the part of home care physiotherapy, Dr. Parina is always there to have that understanding for you. Tele-rehabilitation. This is Digital India. This is Communicating India. So tele-rehab is one of the things that is emerging even in Physiotattva. We are already into the market where a person has to have a good delivery systems. It could be synchronous, it could be asynchronous. depending on like how we wanted to give the tele-rehab, whether through the booklets or whether to have in asynchronous. And synchronous, we have to have the good interaction one-on-one through telepathy. It could be a phone, it could be internet, it could be anything around. Virtual realities are also integrated into part of home care systems with the tele-rehab, and mobile health apps are always present. We are currently having 24/7 physiotherapy in order to address all those kind of tele-rehabilitation from our end. A few of the things that one has to have a good internet and calling capacities. They should the apps I have made it very easier for everybody to have around. A good feasibility of the time and the duration and the perspective. It has to be addressed from the people coming from only a professional medical background, not the other people around, and it could be a feasibility again. So I think that comes to the end of the current trends. I don't want to take that much of time in here. The implementation, I wanted to talk about Physiotattva in here because my company. So implementation in Physiotattva has been having a very patient-centric approach. The moment the patient enters, we start with the assessments and the need of identification, with setting of treatment, with setting of the implementation of new protocols when has to be addressed, and with the family education, as I have already delivered. Research and academics is something that Dr. Sandesh Kadabam has already taken so far with the university intake on the SYSM. And discharge planning. Discharge planning is something I wanted to bring in the notice of discharge planning is the doctors, the physiotherapists, the previous physiotherapists, the ongoing physiotherapists, the future physiotherapists has to be connected in here. So the more the connection has to be made, the more the feasibility of a patient outcome gets better when it has to be addressed. So we respect that, we have to encourage that as well. And follow up in continuity of care. Follow up in terms of having cross consultations, consultations, reconsultations, and getting a phone call, having a feedback, everything comes in that case. So this comes to an end. Thank you so much. These are the future things that, these are the current things that we are doing. We have inpatient facilities starting in just next 1 or 2 days, where we have also addressed the diet and nutrition as a major part of our aspects in the part of neuro rehab, stroke rehab, plus neuro rehab. We have all our online services that are happening in 24/7 that keeps us connected. It has to be addressed, like it is addressed by AI Sathi and automatic chatbot. We have outpatient facility currently. Dr. Sandesh and Dr. Anup has already mentioned that we have many of the neuro centers, many of the clinical centers that we all already running in the part of Bangalore and Hyderabad. We have aquatherapy, again very close to our heart, I've explained, and we have home therapy exercises as well.
Thank you, Dr. Bhanot. Your enthusiasm and friendly approach helps all of us to unveil our knowledge of neuro-rehabilitation at Physiotattva. I call upon Mrs. Neha Kadabams, psychologist and executive director at Kadabams Group, to present a vote of thanks to Bhanot's presentation. Our last speaker for the day, Dr. Shreyas Kadabam. He is here to speak on role of guided intervention in pain management. Dr. Shreyas Kadabam is an interventional musculoskeletal radiologist with vast experience. Completed his fellowship from Mumbai in sports medicine under Dr. Daftari. He has worked in different areas as a consultant specialist in radiology and interventional musculoskeletal imaging. With experience in prominent hospitals, Dr. Shreyas Kadabam has a strong understanding of identifying accurate diagnosis by evaluating previous patient medical history, symptoms, and assessment. His areas of expertise include musculoskeletal intervention, USG guided joint and bursal injections, guided steroidal and local anesthetic injections for tenosynovitis, tennis or golfer's elbow, frozen shoulder, ultrasound guided ganglionic cyst aspiration, and PRP treatment. He is at present pursuing sports medicine degree at an International Olympic Committee. Sir, please.
Hello, everyone. Thank you, Nadia, for the introduction. So I'll be talking about the role of guided interventions in pain management today. So guided steroid injections have a huge role in pain management, predominantly in joints and spine. These are usually tried after other interventions like rest, activity modification, physiotherapy, and oral NSAIDs. These are usually not a replacement for physiotherapy or surgery. These are, in fact, an adjunct. And they include nerve blocks, epidural injections, joint injections in order to control and manage pain. Physiotherapists frequently encounter patients with pain which limits movement and function. So guided pain management can actually complement physiotherapy by providing immediate pain relief to the patients. What is the importance of pain management in physiotherapy? Chronic and acute pain can prevent patient from engaging in and completing therapeutic exercises. So when you address these pain points with targeted treatments, they allow for improved range of motion and function. Pain relief leads to increased patient engagement in the rehabilitation process and improving the adherence to various physical therapy programs. What are the benefits? Now, there's enhanced patient functionality. Once the patient has pain relief, the patient can perform various exercises with less discomfort, improved range of motion, mobility, and strength. These usually act as a complementary tool for physical therapy. So once the pain is managed, they can go into more intensive physical therapy. So they usually facilitate rehabilitation in musculoskeletal and neurological conditions, such as post-surgical recovery, spinal conditions, and complex joint issues. They usually lead to improved outcomes because they shorten your recovery period, and they also reduce the need to take steroids and other oral agents which may cause certain side effects. So what is a physiotherapist's role in all of this? First is obviously assessing, because they often become the first point of contact, and they need to identify what are the pain patterns and what is the exact cause of pain. Next would be identifying whether the patient would benefit from having the pain management shot. So next step would be to collaborate with various pain specialists and doctors to determine when the patient is not responding to various traditional protocols. And once the pain is managed with an injection, they can work on strengthening, flexibility, and functional movements in order to restore full mobility. What are the advantages of localized injections? These are usually quick and easy to perform. There is very minimal side effects. They target pain due to wear and tear in joints and inflammation due to soft tissues. There's also, once there's reduction of pain, they can obviously start off with normal activities quickly. And sometimes when there is a doubt of what is the real cause of pain, they can be used as a diagnostic tool in order to confirm the cause. So when we are talking about image guidance, there are various types of imaging tools which are used. One is obviously fluoroscopy, and these are for use for spinal and joint injections in order to confirm the needle placement. Ultrasound, where there's real-time imaging which is used to guide peripheral nerve, bursal, and tendon sheath injections. CT scans in difficult to access areas such as facet joints, selective nerve root blocks, and sacroiliac joints. We use CT guidance to get to the point. Okay, so what blind injections versus our image guided interventions? So image-guided interventions usually increase the accuracy and precision in delivering medication. So it has an accuracy of about 90% according to various studies. So there is minimizing risk of various injuries to surrounding structures like blood vessels and nerves, reduces the complications, and improves the overall success of the intervention itself. So what are the disadvantages of oral steroids? They're usually not targeted, and only 5% of them reach the desired area. There are various other side effects like weight gain. There is immunity suppression, increase in the glucose levels, and heartburn and indigestion. When do you avoid giving these injections? So when the patient is unwell, it's an anticoagulants of high dose. When the blood glucose levels are not controlled, usually more than about 200, infection at the site of injection or where you're trying to inject, allergic to various local anesthetics, or if the patient is pregnant and breastfeeding. So appropriate diagnosis, pre-procedure planning, injections and injectables, various procedures, and post-procedure management would be the steps. Like I mentioned earlier, an appropriate diagnosis is the key. So a relevant history, performing various tests to identify that is the cause, and using diagnostic tools like MRI, ultrasound, and radiographs to confirm the diagnosis. Pre-procedure planning, one is obviously to confirm the indication, explaining to the patient about the procedure and the outcome, taking consent, discussing the complications, and the various side effects, even though not so many, but infection and bleeding with any interventions, pre-injection site and trajectory planning, and also the key important thing would be to maintain sterility. So the commonly used injectables are local anesthetic and steroids. It is usually a combination of both. So the commonly used local anesthetics are lignocaine, bupivacaine, and ropivacaine. So lignocaine is a rapid onset, short-acting agent. Bupivacaine is a medium-acting, and it usually has a duration of action of about 6 to 8 hours. Ropivacaine has less motor blockade, and it's ideal for perineural and postoperative analgesia. The commonly used steroid for giving the injections would be triamcinolone acetonide, which is a long-acting agent, and it has intermediate solubility. The other agents are methylprednisolone and betamethasone. Betamethasone is a short-acting agent, and it has a high solubility. So we're now moving on to the procedure technique. As you can see there, that would be the probe, which is placed onto in order to identify the site where the injection has to be given, and the needle under direct ultrasound guidance is accessed onto the peripheral nerve sheath or into the tendon sheath itself, and a combination of the local anesthetic and steroid is given, and the needle is slowly withdrawn and the skin site is cleaned. So the accession point, that is the ultrasound probe there, and that's the needle along the axis of the ultrasound probe itself. Post-procedure management would be providing a sterile dressing, assessing for improvement. So usually the steroid takes about 2 days to start kicking in. So it is very important that local icing about 4 times a day is done post the steroid injection itself. And rigorous activity has to be avoided for about 10 days, post which the physiotherapist can start off doing slower movements, and obviously providing a contact in case of any post-procedural complications, even though usually they're not too many. Some of the questions which they commonly ask would be, how long does it take to act? So the local anesthetic, which is given as a combination, acts for about 4 to 5 hours, after which it wears off. Then the steroid takes about 2 days to start taking its effect, and sometimes it takes its peak effect only after about 4 weeks. Local icing for the next 2 days, and if the patient is in a lot of pain, you can give painkillers as well. How long does it work? So it's variable from person to person. It may take about 6 weeks to get good results. about 10 days post the injection, the physio can doing pain, after the pain relief, start doing slow activities and increase the intensity itself. Steroids can reduce the inflammation for months to years. So most often during the acute phase, when you give a steroid shot and they improve, they might not need one later in the future. Like I mentioned earlier, this is some of the types of injections. One, this is a nerve root block. So a local anesthetic and anti-inflammatory medication is given to certain specific nerves in order to block the pain signals. The common types of these are peripheral nerve blocks and selective nerve root blocks. This is an image of a suprascapular nerve block, and what we can see there is the sphenoglenoid notch, and the needle is the needle is basically accessed onto the sphenoglenoid notch, and the injection is given. These are joint injections. These are targeted injections of corticosteroid or hyaluronic acid into the joints for pain relief and inflammation reduction. So common indications are osteoarthritis, shoulder pain, knee pain, various other acute inflammatory joint conditions. This is an image of a glenohumeral joint injection given under ultrasound guidance. So what you can see there is a needle which is accessed onto the glenohumeral joint, and an injection is provided. Epidural injections. These are injected into the epidural space of the spinal cord, used for radicular pain, which is caused due to various conditions like disc herniation and spinal stenosis. And indications are radicular pain, back pain, leg pain, and various other inflammatory conditions. Bursal injections. These are very commonly done. The commonmost ones would be the subacromial bursal injections and the trochanteric bursal injections, and they're usually caused due to overuse and trauma. Tendon sheath injections. Injecting a steroid and local anesthetic into the tendon sheath is very helpful in order to reduce the pain in case of acute inflammatory conditions. So cases like tenosynovitis, which are biceps tenosynovitis, decurvence tenosynovitis, and obviously the common ones like tennis elbow and golfer's elbow usually benefit from these. This is an image of a biceps injection. The patient is in sitting position, and the injection is given into the bicipital groove near the tendon sheath itself. This is one of the case examples. So when the patient presents usually with chronic low back pain due to any herniated disc. So based on the initial assessment, if the patient is unable to engage into full rehabilitation due to pain, then an epidural steroid injection is administered under CT guidance, and post the injection, the patient's pain levels significantly decrease, and so they can do the exercises, and once the pain is managed, they can obviously push themselves better. So the patient reports significant improvement in function and pain management, allowing for ongoing full rehabilitation. Another such interventional procedure is a calcium barbotage. So calcium deposits, be it hard or soft calcium, usually cause a lot of pain to the patient, limiting their movement. So some of the indications are calcific tendinitis and ligamental calcifications. So this is an X-ray image showing the hard calcification and an ultrasound image showing the soft calcification. So this is an image of a calcium barbotage, where first we usually give a local anesthetic into the axis points and a larger needle, usually an 18-gauge needle, which contains of a local anesthetic combination with normal saline, is given onto the soft calcium itself, and multiple pulses are given. And the calcium deposits actually come back into the syringe. And post which a local anesthetic and a steroid combination is injected around there, and patient usually benefits from these significantly because the pain reduces. Some of the other procedures which usually help in pain management would be ganglion cyst aspirations, Baker cyst aspiration, trigger finger release, mucoid ACL aspiration as well. Some of the challenges and considerations would be during these image-guided interventions. One is obviously the patient selection. Not all of these patients benefit from giving a guided pain management. So it's important to take a good history, understand their comorbid conditions, and also the severity of pain. A proper counseling has to be done as well. Some of the side effects and risks, even though are little, obviously with any interventions, there is a possibility of infection and bleeding or any nerve injury. Because we are going under guidance, these risks are very little. Cost and access, some advanced pain management techniques are not so readily available and could cost a little bit for the patients as well. So guided pain management can be very valuable adjunct to physiotherapy for patients with chronic or acute pain, which will facilitate more effective rehabilitation. So reduced side effects, targeted pain relief allows for patients to engage in therapy, improving mobility as well as the quality of life. So collaboration between the physiotherapists and pain management specialists is very essential in order for optimal patient outcomes itself. Thank you.
Thank you, Dr. Shreyas. I call upon Dr. Parina Lama, Regional Head at Physiotattva, to present a token of appreciation for Dr. Kadabams for his insightful presentation. As we conclude this continuing medical education conference, I would like to take a moment to reflect on the wealth of knowledge we've shared. We have been fortunate to gather insights for renowned experts in the field, and I hope that information presented will have a lasting impact on our practice and patient care. Moving on, we have an open house for our question and answers. Now, we are going to have an open house. Feel free to ask any questions or doubts you may have from the panel of experts. I invite our panelists, Dr. Murali Krishna, Dr. Yolana, Dr. Bhanot, and Dr. Shreyas Kadabam for our open house question and answers. Ladies and gentlemen, all your queries and questions Can we now have our question and answer round? Anyone from the audience? Okay, let me begin. My question is with Dr. Murali Krishna. Sir, do you feel the intervention of psychologists in neuro-rehabilitation team is as important as occupation therapist and speech therapist on a daily basis?
Generally or localized to any certain disease?
No, at a general level, the importance of psychologists in neuro-rehab on a daily basis.
Yeah, it's better to have daily psychological sessions with both with the patient and the patient family. In that way, they should understand what is the burden to them. So in that way, we can reduce the, post depressions and all psychological issues will be better, will come down.
Okay, sir. Thank you, sir. Anyone from the audience to Dr. Murali Krishna? Come on, audience. Okay. My next question is Dr. Tuyolana. Is it possible to arrange a high-end robotic machine in India in your R&D centers so that we can get a first-hand experience on real patients?
it will be also, of course, amazing, but I will probably send this question to the sales team of India, who is, like, let's say, more responsible for these aspects. But if this makes sense, and then if the like demand for this will be that high, then from my perspective, it will be, of course, very beneficial.
All right. So would you pass on the question to any one of your representatives from India?
Can I?
My question is it possible to arrange a high-end robotic machines in India in your R&D so that we can get a first-hand experience on real patients?
Okay, so I'm so happy that you are aware about what I am going to discuss afterwards. She is revealing. Yes, BTL has got 5 R&D globally, and one of the R&D in India is out of 5 global R&Ds of BTL technologies. And we are all lucky that that R&D is in Bangalore. Now, as a matter of fact, for any kind of a research and development for the company like a global BTL mode of operations and some standard operation plans, R&D works are always confidential things. So whatever we are going to do in the R&D setup, it is completely a confidential part. But in the process of making some rehabilitation devices more effective for the Indian perspective, yesterday we had a very lovely dinner over that. We have discussed these things with Sandesh and Anup. So probably we are thinking about something better than with collaboration of our brotherly partner from last 6 years, Physiotattva. And I'm actually looking forward some big thing in a near future in India, and certainly that will start with Physiotattva because of your extreme, vast base. Thank you so much.
Thank you so much, sir. Anyone else? To Dr. Yolana? Are there any questions from the audience? Yeah. So your name?
Yeah, myself, I am Srinivas Naik. I work as a physiotherapist at Nimans. Yolana, you have done your schooling in musculoskeletal. How did you develop that interest towards neuro?
How do I personally developed in there? I do have also experiences from some neuro-rehabilitation clinics and neuro centers in Czech Republic. So this is like the background that I have from there. Because in Czech Republic there is quite a big developed, like not chain, but general like treatment of neurodegenerative diseases, and we also have quite big advanced rehabilitation centers where I participated. So that was the part where I gained experience in neuro.
Thank you, ma'am. So does that answer your question?
And thanks for an answer.
Moving on, my next question is to Dr. Shreyas. What are the short-term and long-term outcomes of guided intervention for pain management?
So short term, usually we expect about 70 to 80% pain relief in the condition. Most often, if it's an acute related pain, then because the inflammation reduces significantly because of the steroid injections, we usually do get good benefits. In terms of depending on the activity of the individual as well as if it is an inflammatory condition or not, the patient might not require another injection at all. Once they sail through the acute phase, and with physiotherapy and other just regular activities, the pain just goes by and the inflammation might not pop up again.
And for the long term, sir?
Long term, like I said, the patient might not require anything at all because usually most of these conditions come in acute phases. So once you address that acute phase, if they come back with an acute phase again, we can obviously address it. But more often, they might not need anything again. So maybe again, after a couple of years, if they do have another acute bout, maybe treat that acute bout, but they do benefit significantly from that during that.
Thank you so much, sir. Anyone from the audience? Yes, sir.
Yeah, my name is Jinu. I hail from a palliative care physiotherapy background. I work for a hospice. So I was listening to nerve blocks, and we do come across cases where the pain relief sometimes doesn't happen even with opioids. So nerve blocks in palliative care population, any light on that?
Yes, I mean, so I I would say depending again, it really depends on the condition, and does significantly help. The most important thing would be to identify what nerve root block has to be done for that particular condition. So let's say if there is back pain, obviously, and you've identified which particular nerve root is it which is causing that issue, and which side, you identify all of that, and when you under CT guidance you go into that region and you give a nerve root block, it really significantly helps. But when it's generalized and you do not know what is the cause, more often if it is a palliative care patient, then what happens is there are multiple levels where there is it's getting affected, and it becomes the results might not be that great, but definitely they do get at least what I have seen is about 40 to 50% pain relief, post which they can start doing some kind of activities in terms of strengthening. All of that will help significantly.
Great. Thank you, sir.
Thank you so much, sir. Do we have any more questions? All right, my last question to Dr. Bhanot. When we do neuro rehab, initial 6 to 7 months are a golden phase, but after which the progression becomes stagnant. Is it because of the limitation of the rehab, or is there any new intervention that can be done?
So, when we say the chronicity of the stroke, that post-stroke residual palsy or paralysis, right? There are multiple things we can do. When we say what are the multiple things, it could be a traditional approach, it could be NDT brainstorm, it could be a novel approaches, be it with the biostimulations, be it with the repetitive task, be it the specific task training. Many other things can be done by that.
Thank you, dignitaries, for your thought-provoking questions and answers. We appreciate the engagement and insightful discussion. This concludes our question and answer session. Now, our last segment. Ladies and gentlemen, with pleasure, I invite Mr. Puneet Trivedi, Managing Director, BTL India, to deliver us some insights on BTL India. Mr. Trivedi drives innovation and excellence in aesthetics and medicine. Under his visionary leadership, BTL has achieved remarkable milestones. We thank him for his invaluable contribution to the CME event.
Thank you so much, Nadia, for a lovely introduction. Thank you so much, Doctor. Before I start, I just would like to share. Food is ready. It is almost 1 hour. We all are sitting over here. So I wish to take 5 minutes break. Not for me, but for all of us. Pick your glasses, pick your things, come back, have a bio break, and then come. By the time, I would like to see whether my 5 minute long presentation will work or not. Because I saw some videos are not going on correctly, so I don't want to do anything which may be missed by this lovely audience in the evening, because my video is not at all any scientific. It is just because of my emotions. I'm not here, I'm not a perfect, I'm not a doctor, I'm not a physiotherapist, I'm not a finance guy, I'm not a account guy, I'm not a marketing guy. I'm an emotional guy who has got just one emotion, and that emotion is 100% in sync with two more guys here present in this room. One is Dr. Anup and one is Sandesh. Where is Sandesh? And that is passion. So before I would like to take your time, I wish if Sandesh and Anup, you please be here in this room. So anybody can call. I cannot see Mr. Sandesh in this room. I need him. Otherwise, I cannot do anything in this room. And enjoy. Take your drink if it is there. Please pick your drink and water bottle, whatever you want. Have a 5 minutes break. This is nothing science. This is nothing. It is very lovely. 5 minutes. Sai Sandesh bhai, I just wish that you should be here. It is very emotional because I'm not a technical guy. I'm a passionate guy, just like these two gentlemen. And trust me, my team reminds me how I have grown in last 6 years with BTL. We are heading towards 10 million sales this year. This is amazing job by my team. Trust me, I'm so happy to share with you the way I see my son growing every day. I have seen in last 6 years, BTL has grown in Indian market. And that is why was not a planned slide. Thank you so much, Panna, to put this slide just half an hour before. Just now, you did it for me. Thank you so much. So, this is my emotions and this is the passion. Now, I would like to share one more interesting story. Do you know how much 3 years old young boy looks like? 3 years old? Exactly. Physiotattva and BTL is 3 years young boy, a toddler. We started our journey 3 years back with first clinic of Physiotattva in 2021. Sandesh, I'm right? We are 20 clinics old now. The biggest in India. The biggest partnership from any company with any of the organization. No company can have this kind of a proud feeling. Oh, I have got this Physiotattva and all those clinics. Before they will open, before they will, interior designer will come, they will finalize the deal. My order is fixed. I don't need to send my salesperson. I don't need to send anybody. I just want to hear a phone call from either these two of the gentlemen. Hey, Puneet, I'm opening in the north of the Karnataka or north of the highway, Bangalore. Send these many machines. This is what is a trust. The trust our kids are having on us. The trust our brothers are having on us. We have full trust, like a brother's trust. It's a family. So this CME is not only a Physiotattva or BTL CME. It is a joint, collaborative, emotional, passionate partnership of last 3 years. Guys, celebrate this. Next slide. 93, 31 years back, one young man in Czech Republic, Prague, thought about creating something. And the first name, I asked this question to my owner. This is a family-owned company. As of now, we have not listed BTL anywhere in the stock market. So it's a very cash-rich company. And the owner, he was there in India every 3 to 4 years. So once I meet him, so I asked him, he said, the first name of BTL was Beauty Line. And Beauty Line doesn't go with physiotherapy. And they have got multiple domains. Cardiology, aesthetics, physiotherapy, now it's neuro-rehab. So after 30 years, what that Beauty Line has become as a BTL Global, I wish to play a small video. Can we have our dim lights in the front? Just enjoy this video and feel the passion about a person who created this company.
When you look back at the last 30 years, what do you think about? You think of the music that defined you, that song you listened to the first time you fell in love, or how the way you listened to it evolved over the years. Do you think about your family, or that day when you finally chose your own family, and it doubled in a moment, and continued to grow and grow? Do you think of the people who shaped you, or the people you helped shape, the communities you built? At BTL, on our 30th birthday, we think of our family, our engineers, our partners, and our customers, and how they've shaped our technologies over the decades. One spark becomes a device. One device becomes two. Two becomes four. Until now we have over 70 branches and over 2,800 employees worldwide, all while staying true to our core as one family. And the more we've evolved, the more lives we've shaped. One patient can walk a little easier, breathe a bit deeper, gets a little bit stronger, a little bit more confident. Cardiology, pulmonology, physiotherapy, urology, dermatology. Each advance we make helps our customers improve the life of a patient. One patient becomes two, two becomes 20. And before we could even blink, 1 million in our family. Then almost in a moment, it doubles. When you're helping doctors to shape the lives of millions, you've built more than a company, more than a community, but multiple communities on multiple continents.
Hey guys, it's Michelle E. West, and I am so excited to be part of the scholarship program for BTO.
Providing scholarships, breathing life into our neighborhoods with art and murals and music, finding new and creative ways to build things, perpetually breaking new ground to help our customers grow their business, helping our family get bigger, get stronger, and get real. And all of this without implants and artifice, nothing fake, just a stronger, more youthful, and more confident you. And while technology can get scarier by the day, our technology isn't here to replace you or ensnare you. Our technology is here to empower you, because our customers empower us. They make us better and make us stronger. Imagine what we could build together with another 30.
So 2023, we celebrated our 30 years. We are 31 years old now. And in just 1 year, from 70 branches globally, we are now 80 plus branches. This is the pace of growth what BTL is giving to the global market. Next slide, Vanna. And now we have got state-of-art products across these 4 divisions: physiotherapy, robotics, cardiology, aesthetics. Next slide. Physiotherapy, I'll just run through these slides. These are the products and they're, just read it. I just do not want to, we all are knowing about these products. They're all very familiar with Team Physiotattva and in the Physiotattva along with physiotherapy fraternity. Next is robotics, which is the new thing. And we are very proud to launch this in India. Let me share with you one very interesting thing. This year, BTL Global has started this robotics division as a launch campaigns across the globe. And India has been chosen by the BTL management, global management, much before the US market, much before the Australian market, much before the Gulf countries. And that is what is the power of India. So I'm proud Indian to take that flag ahead. And this is what is going to happen very soon, probably in your city. Next slide. Cutting edge solutions, everything has been covered by Zolana. So this is what is our BTL robotics portfolio. This is our force. Next slide. Cardiology, next slide. Again, the portfolio detail. Aesthetics, these are the devices with aesthetics. Next slide, please. Next slide, please. This is the current stats. From 70, we have moved to 80 plus direct offices, 52 distributor countries, 3,500 plus employees and 500 engineers. This means the R&D team. Out of 500 plus, approximately 100 are there in your city. R&D for BTL Bangalore. And they are all Indian brains. Nadia, some things are confidential, but yes, we can do so many things in Bangalore. You understood that. Nice. Next slide, please. These are the names where we have got our R&D centers for knowledge for everybody. Next slide, please. This is what is our strength. More than 200,000 professionals are using our device. Huge. Next slide. 300 patents right now we are carrying. Next slide. The manufacturing unit, Sandesh was putting me some pressure last evening, and it is truth, it is reality. We are now moving even a bigger space. 2 months, our manufacturing would be little bit low and slow. So if they need to put some order for BTL, we need to wait at least for 4 extra weeks. This is a reality. We are growing not only in India, globally. Next slide, please. So wellness and BTL robotic solution, we have already talked about. I'll just run through in 2 minutes. Next slide. R-Force, just a video. That time it didn't work. Hopefully it works now. Please. Next slide, please. This is going to be our force. The other is our gate. Show the video. This is going to be our gate. So I'm showing the videos of about our entire robotic segment. Next slide, please. Our touch. Next slide, please. Video, please. I'm not the expert, but I know something. Dr. Morley is here, and we all understand strokes after that neuro-rehab. We also want synchronization between our cognitive reactions and the body movement put together. So these highly actively designed video games, along with those things, will repair everything in put together in totality as a package. So we have got more than 100 video games, and every day our team at R&D are developing such new games to make more effective cognitive impairment and all these things possible for us. Next slide, please. This is the last one. Thank you so much for this patience, hearing, and listening to my emotions. Yeah, ma'am, please. Yes, ma'am. Thank you. Thank you so much. Please, ma'am.
I have been with the BTL family for years. Sandeep, he vouches for it.
Yes, ma'am.
BTL is something that I'm very fond of. And one call away, Sandeep comes immediately.
Yes.
I have a small request.
Yes, ma'am.
If something goes wrong with the equipment,
Okay.
you're talking that Bangalore is an R&D center and everything, I do not get a backup.
Okay.
I need to get a backup.
Okay, noted.
So
Sharmaji.
please, I think you need to organize. And every time, suppose something goes wrong, it has to go all the way to your mother country and then come back here. That takes me 4 weeks. That's pretty long.
Correct.
So when you're boasting about so much of improvement in the whole process,
Correct.
and the kind of countries that you have occupied, and
Yes.
this, congratulations, no doubt about
Yes,
it.
yes, yes.
But can you be able to solve? Are you able to solve this little
100%.
issue that we have? This is my only request to you.
Thank you. I can understand what you must have felt when these situations would have come to your place where device was not working and we took some extra time. I understand it first. I acknowledge it. It should not be a case where you need to wait for 4 weeks. Things are going for an improvisation from our side. I can just now say one thing. That is why my first slide was very emotional. It is 6 years old BTL under my leadership, I would say, and last 6 years it's a difference from previous 6 years, and I'm still in WIP mode, work in progress. But I can assure you, if Sandeep is here, Sandeep has every time given these feedbacks to our technical team from 2 engineers, ma'am, in 2019. We have grown now 4 engineers. So it is double. And this is something which is all together at Bangalore. I love this statement. Wish me good luck the day I will have this kind of finances with me. My finance guy is sitting over here because the day when it would come when we can have all the headquarters station with the engineer, but we need to finance it. We need to give the salaries and everything. That is why we are here. Sandeep, your targets are 4 times and then we will have 1 engineer at your place. I think, ma'am, I am in a work in progress. Trust me, it is all passion. But yes, you are right. Things don't go with all the time with passion. We need to have the ground realities. We were having some lacunas in past in terms of engineering support. It is improving. I can tell you this. It will go on the improvisation trend. Trust me. Thank you so much. I have taken. Thank you. I have taken your feedback. Anything, anybody else would like to ask something? Thank you for this lovely time. I wish to share, we are going to have something very specific soon. So we have more or less decided to install entire robotics rehab soon in India, where entire robotics would be here in the city, Bangalore, for India first time. All the devices under the flagship and banner and the leadership of Sandesh and Anoop with Physiotattva soon. Congratulations, and I'm so happy. Thank you. Before we go on, this is a small video. We have celebrated our 30th birthday. You can see, you can just enjoy this video, and my time is over. ठीक है. So vote of thanks, then we'll play the video. Yeah. You can announce it and I'll do that.
Thank you so much, Puneet sir. That was emotional. Coming on to our word of thanks, I warmly invite our tireless and dynamic Dr. Anoop Brahmbhatt, co-founder, chief physiotherapist, and chiropractor at Physiotattva, with an experience more than 18 years. Ladies and gentlemen, to this man himself.
Thank you, Nadia. Thank you all. Respected dignitaries, esteemed faculty members, and all distinguished guests and fellow physiotherapists. On behalf of entire Physiotattva family, I would like to extend my heartfelt gratitude to each and every one of you for making this event and CME resounding success. To our keynote speaker, Dr. Murali Krishna sir, Dr. Yolana, Dr. Shreyas, he's more of a brother, Dr. Komal, my colleague, your expertise and insight have enriched our knowledge and inspired us. Your contribution will have a long-lasting impact on our practices. To all our participants, your active engagement made this event more meaningful and lively. Special thanks to Aarti ma'am for bringing that particular topic and giving a thumbing impression that we all are one family. To our knowledge partner, BTL India, we appreciate your commitment to advancing physiotherapy education and uplifting profession. When Puneet ji said that we are emotionally connected, yes, we are definitely emotionally connected. Special thanks to Team Physiotattva, our coordination team led by Shruti ma'am, our corporate team, our production team, and one more special thanks to Royal Orchid team for working day and night to make this event successful. Thank you. Today in this hall, we really feel honored. We really feel heartfelt gratitude, full of gratitude that today all physiotherapists breaking all the boundaries. If I start, the man, BPN President, Dr. Jayanand sir is there, Dr. Dhananjay sir, Dr. Parthipan sir, all Geeta ma'am, all the people from the entire fraternity, we would like to personally thank them that they have taken a time, made sure they are here to appreciate Physiotattva and BTL India. We should really appreciate and clap for them. It's a big round of applause for them. I'm not able to hear proper voice. Big round of applause for them. On behalf of Team Physiotattva, and we come from the root of Kadavam's group where our values, our principles, our ethos comes on a front where we value our partnership, we value our relationships, we value each one of you here. I would like to personally make our team reach out to the people who have come here today, give the memento, give the token of appreciation, give the token of respect what they have shown today towards the team Physiotattva and towards us. Thank you. I'll start the name. I would request Dr. Daritri and Nadia to reach out to each one of them. Give a small token of respect and small token of appreciation to each one of them. I would want them to stand wherever they are sitting on this wonderful hall. Dr. Dhananjay sir, the sir has been doing amazing work in the Bangalore Physiotherapy Network. We all, Dr. Aarti Prasad ma'am, I don't want the clap should be stopping. We should keep, ma'am has been doing, we all look up to you ma'am. Thank you for being here today. Dr. Parthipan sir, big round of applause man. We should not, this is the time where we should really appreciate the real hero behind the physiotherapy team. Dr. Vasantan sir, who was my principal once upon a time, really appreciate his effort in the field of neurophysiotherapy. Dr. Geeta ma'am, who is heading the Fortis Hospital. Big round of applause for ma'am, who has been doing amazing work. Dr. Gladson sir, Dr. Partha Sarthi sir, Dr. Than Lakshmi ma'am, big round of applause for ma'am. We have Dr. Sumita ma'am, who has been doing amazing work in the field of pediatric physiotherapy. Guys, we should appreciate her work. She has been doing amazing work. And we all look up to her when it comes about the pediatric work. Dr. Parameshwaram Reddy sir. Ramesh Debur sir, Dr. Ramesh Debur sir. Dr. Divya and Dr. Srinivas. Dr. Divya from HCG Healthcare at Home. And Dr. Srinivas sir from Vaidavi sir. Dr. Sita Raman sir. Dr. Nav Bharat sir. Sir is a principal of the Florence College and doing amazing work for the student level, and we really appreciate your work, sir. Dr. Sri Hari sir from the Dayanand Saga. Dr. Srinivas Nayak sir from the Nimhans, and really kudos to you guys. Wonderful job, guys. Big round of applause for all of them. Thank you all. Done. We are waiting for Dhananjay sir, and I think we are done. Okay, moving ahead. We look forward to work with each and every individual present here today at the individual level, at the group level, at the university level, or at the college level. We want to make sure that we bring best practice in India, especially in the field of physiotherapy. Together, we can change and bring the culture of one big family. Ultimately, when we go to a sleep in the night, we all forget one thing, that we are a physiotherapist. Before physiotherapist, we are one good human being. We should take this sentence. Yeah, we should make sure that before, see, knowledge, physiotherapy, we all studied similar. But before we put our foot in the clinic, if we take this sentence, that we all are first human being. We should make sure that we meet each other, create one big family, and I am sure with today's event, we have started. Looking forward to meet you all. Thank you all. Jai Hind, Jai Karnataka. Small thing wanted to add. We have one more esteemed guest with us, Dr. Naveen from Manipur. He heads the PMR, and we really honored you are here, sir. Really thank you, and we really appreciate you be here. Thank you, guys. This was our way of saying thank you to all of you. We really feel today emotional. Today, as a CME or as any event for a team Physiotattva, all my colleagues are standing backside and they are pushing me today. But as a team Physiotattva, we feel really happy and we are really honored to have you all seniors standing with us, giving us a back and saying, don't worry guys, we are there. Thank you all.